Welcome to our IDR clinical case discussion webinar series this evening by Professor Jose Carlos Martins da Rosa, who joins us this evening from Caxias do Sul in Brazil. This event is being hosted by Camarlengo Dental Institute. I am your director, Arturo Zarzar, and we will start in a few minutes. In the meantime, let me share with you that this webinar will be recorded and sent via email to all participants for your review. When Dr. Da Rosa asks a question, or if you wish to make one or comment, please activate your microphone to speak. While Dr. Da Rosa is talking, we appreciate everybody having their microphones in mute. Feel free to also text any questions to the group chat, and our Camarlengo staff, Alison and Sanin, are connected to address your needs, and of course, myself. Dr. Da Rosa, good evening. Thank you very much for making time for us and to share this fascinating surgical and restorative technique that you have developed for over 15 years. You have the floor, and I'm looking forward to enjoying this type of new style of webinar where we have an open mic and people are welcome to participate, make questions, and have a direct access to you. So thank you very much, sir.
Thank you, Arturo, and all your team to give me the opportunity to share my experience with the participants. I'm gonna share with you about the immediate dental velar restoration technique. This is not new anymore because this technique has been done for many professionals around the world. I personally trained more than 2,000 colleagues worldwide. So we have lots of people besides this group that I trained, lots of other people that are applying this technique around the world and get also outcomes related to this methodology of management of compromised sockets. This is our goal today. Like this case that we have in the bottom of the screen, we have a big bone loss, as you can see here in this image. So it was performed tooth extraction, bone reconstruction. As you can see here, first, it was taking the bone from the maxillary tuberosity. The bone was reshaped according to the defect configuration. It was inserted in the receptor side, and it was manufactured immediately, our provisional restoration. And here you can see the outcome after 3 or 4 months. And here you see the CBCT scan after 4 months. And you see also, I want to call your attention to the amount of bone that was remodeled at the facial aspect of this new implant. So this is our main goal when we apply the IDR technique in our daily practice. And here this picture is awesome because this was the last time that I opened a flap to manage a compromised socket when it's missing completely the buccal wall. As you can see right here, there is no buccal wall. And can you imagine the last time that I opened a flap to manage a cases, very complicated cases like this, that is missing completely the buccal wall? It was in 2006. Since then, we never opened any flap in the management of compromised socket, regardless if it's missing 1 wall, 2 walls, 3 walls, or all walls around the condemned tooth. So nowadays, since 2006, we've been using this methodology, using flapless surgery in order to manage compromised sockets in such a case like this. So this is our daily routine. And after we do the site preparation without opening any flap, we do the site preparation, we insert the implant, preferable using a guided surgery. And doesn't matter, here you can see in the screen, we have 2 ways to manage compromised sockets, but doesn't matter if you use only bone graft or bone plus soft tissue graft in the management of the buccal wall that was gone. This is the outcomes that we are looking for. You see in both different scenarios, a relevant soft tissue, the maintenance of the anatomical contour of soft tissue, and the maintenance of the papillary height position. This is what the patients are really looking for. So if we would discuss a little bit about IDR, we have been using this methodology for more than 16 years. And we have many clinical cases with more than 15 years of follow-up. And we still are evaluating these cases nowadays in order to have a look if the soft and hard tissues is still there. And the outcomes is really impressive. And what does it mean, this IDR technique? Just to give a summary, how does it work? We extract the tooth, we insert the implant in the right position, and doesn't matter if we use only in the analogical way or the digital way using a guided surgery, but the implant has to be placed in the correct three-dimensional position. This is one of the keys in order to succeed with the IDR technique. What's the next step? We do the bone reconstruction. Like in this case, it was missing completely the buccal wall, and we harvest bone graft from the maxillary tuberosity. We reshape this graft according to the defect configuration, and we insert it immediately in the underneath the soft tissue without open any flap. And here you can see the amount of bone that was restored at the facial aspect. And what's the next step? To perform my provisional restoration. That's the whole sequence of the IDR technique to be applied in our daily practice. And when we take the bone from the maxillary tuberosity, what are the complaints that we expect from the patient? No complaints, because the patient doesn't suffer with any swallow, any pain, any discomfort. So we have a very low morbidity in the receptor side. And we have already performed this technique for more than 16 years, as I said before, and we performed more than 600 clinical cases. And when we perform the IDR technique, what's our main goal? First of all, to get a peri-implant soft tissue biotype modification, and it changed completely this scenario. And sometimes we can add connective tissue graft for some reason, but most of the cases, we don't use any connective tissue graft. As for example, the case that I showed before, we didn't use any connective tissue graft in order to change completely the scenario about the biotype modification. But to understand better the IDR technique, we have to think a little bit outside the box, because we have to keep in mind that we never open any flap. We only use autogenous bone from the maxillary tuberosity, and maybe it's a little bit the treatment planning that we usually offer for your patients in your daily practice. Today, I would like to share with you one clinical case. In this clinical case, as soon as I present for you this clinical case, that's the question that I will ask you. What would you do in your daily practice in order to manage this clinical case without IDR? And after that, I would explain how to manage this clinical case using IDR. So this is the clinical case. This patient had a big problem in the upper left central incisor, this one. And I have to say that we have the balance between the gingival margin. This is really good. The papilla is in a very nice position. But if you see this CBCT scan, you will realize that the patient lost completely the buccal wall from the crustal bone to the nasal bone. So we have to restore not only the buccal wall that the patient had lost, but the bone that this patient lost above the apical part of this condemned tooth. And have a look when we sound this case, and you see here the periodontal pocket, and we have 5, 10, 15 millimeters in length. So just a confirmation that the buccal wall was gone, and the remaining bone above the apex of this condemned tooth was lost. as well. So I can treat this case for sure as a compromised socket. Please, Arturo.
Quick question. So before we get into a more elaborate part of the case, a few questions from somebody that has not seen the patient, right? So question number one, is that tooth moving?
This tooth?
Yes, is the tooth moving?
Yes. This tooth, this patient, let me tell one more information about this case. This patient had an accident, and this tooth came out, and she tried to reinsert this tooth. She tried to save this tooth, but she did not succeed. And she was suffering with pain and mobility, extra mobility, because we didn't have the presence of the buccal wall anymore. So we have two issues to be managed. The quality of the soft tissue was quite thin. We have the presence of the huge infection, and we also have the total loss of the buccal bone wall. So how to manage a very challenging clinical case like this in your daily practice? That's the main question to discuss with you today.
So I'll tell you what I know a few doctors would say. I'll tell you what I would do, and then we'll open mic for someone else who wants to share.
Excellent.
I know that a few doctors would say that if the tooth does not have a two-dimensional mobility, meaning in two different directions, then the tooth should not be removed, and an apicectomy should be performed, and just keep the tooth there as it is, to address the mobility aspect and the infection. Since I'm an implantologist, I don't agree with that approach, but I know thousands of doctors would make that choice or that preference.
Arturo, we would go into this direction if we have the presence of the buccal wall and we have the infection and the bone loss only at the apical part of this condemned tooth. We would go in this direction, but we have to consider that this patient lost not only the buccal wall, but also the remaining bone at the apex. So this tooth is completely indicated to be extracted. So we cannot save this tooth anymore. So now the question is, how can we manage this clinical case?
So I'll share with you how I have done it before I learned about IDR with you. And the way I used to do it was an open flap, big flap. You have to extract the tooth. You will have a big bone fenestration. It's going to be a big wide opening. There's a lot of granulation tissue usually there. So you need to scrape out, clean up, disinfect. I would use ultrasound to clean up the bone to make sure it's perfectly nice and clean. I would place the implant, and with the open flap, I would see how the implant threads would be exposed. Then I would use, I know you're already smiling, I would use granulated allograft, a bone graft, and then I would use a membrane to protect and fixate that bone graft. Then I would, reposition the flap, a very sophisticated suture to keep everything in place, not easy. Many implant cases fail at the very end in the suture. But that's how I would do it. That's how I have done it until 2019 when I met you. Since 2019 and forward, I would do the IDR. But I used to do it that way. What do you think?
If you go what the literature has recommended to us for such a long time, we would go into this direction. We would extract this tooth. This is what the literature, most of the articles and the authors in the literature has recommended to us for such a long time. We would do the tooth extraction to wait for between 4 and 8 weeks. After that, to do the second surgery, maybe we can use most of the literature would recommend to us to perform a guided bone regeneration in combination with membranes. And we will close the flap again, second surgery. And we would wait for, this is what they recommend, to wait between 6 to 9 months to do the third surgery. What's the third surgery? Implant placement. And maybe in the third surgery, we would add some more extra bone in order to improve the thickness, or maybe the thickness and height for vertical and horizontal augmentation. Sometimes it's necessary. And we would wait maybe for more 4 to 6 months to do the fourth surgery. Fourth surgery means we would, in the fourth surgery, we would perform the implants uncovering. But for sure, one of these steps, one of this stage, we would add some connective tissue graft, extra graft, in order to improve now the gingival margin architecture position, to give back the outline of gingival margin and the papillae in its original position. That's what the literature would recommend to us without IDR. And maybe most of the clinicians around the world would go into this direction. But if we go into this direction, probably we will expect some unpredictable of the outcomes. What do you mean, Jose Carlos, when you say unpredictable of the outcomes? Because we are talking about the excellence in aesthetic. What does it mean, excellence in aesthetic? Is to give back the outline and the papillae position in its original position, or to improve all of this if it's necessary. So, but this is the outcomes that the patients are not looking for anymore, because they need to solve everything in maybe in one, or at the most in two surgical procedures. If we go to IDR procedure, you will manage everything in one single shot, one single surgery, without open flap. This is make difference for your daily practice. I'm sure that will make difference. This is what I'm feeling in all the courses that I've been giving worldwide. This is what the feelings that I may have for the participants, because all of them usually say to me, the IDR changed completely the way to manage compromised sockets. It will make my life easier, and for sure, the life of this patient much more predictable, because you can offer a better treatment for your patients without opening flap. One surgery only, less morbidity, and better outcomes. This is all the patients are looking for, and outcomes like this.
One of the things that has happened to me after I met you is that I started to remember multiple cases that I wish I had known about IDR and I was properly trained on it to, how can I say this? It became more easy for me to identify past cases and new cases now that I have the IDR concept in my head. Now that I know about IDR, my eye goes directly to say, okay, this is a perfect case for it. I recently posted a couple of cases that have cost somewhat of more than 2,000 comments in social media. But I feel bad about the fact that before 2019, I did not have that know-how. And I wanted to take the opportunity today that's pretty much what you and I want for our fellow colleagues. Yes, this is an enormous benefit for the patient in so many ways, but also to the clinician, because you have to dedicate less time and less appointments to actually be empowered to offer a success treatment plan to your patient. And honestly, I did not have that until I met you. So now I pretty much look at everything, and I want to fix everything with IDR. And it's just something that is happening to me. I'm sure that there's like a before COVID and after COVID I think clinicians can honestly say that there's a before IDR and after IDR once they learn the entire complex content behind IDR technique.
Yes, yes. This is what I believe in. This is my mission, to spread the technique as much as I can worldwide in order to offer for your patient the best treatment ever in the management of compromised socket. Have a look at this case. After the tooth was extracted, we confirmed that the facial wall was gone. But remember, not only from the crestal bone to the apex, but above the apex of this condemned tooth. So how can we manage that without IDR technique? And have a look how thin the soft tissue is. It makes difference. It makes a lot of difference. You realize that the gingival thickness in this case was barely 0.5 millimeters in thickness. So we have to pay attention that in the management of compromised sockets. So how can we do without IDR? Is it predictable? As soon as we extract this tooth, probably the gingival architecture is going to be in another position. So how can we give the papilla, the gingival architecture in general, to give back in its original position without using a flapless procedure? Because all the techniques available in the literature, they recommend to open a flap, to do a big flap in order to manage a case like this. I always say something like this from the stage. That's the best treatment that you can offer, for example, for your daughter, for your wife. Are you convinced that that's the best option to use in your daily practice? So let's give me some more extra information about this case, because in this case was managed using IDR for sure. I didn't open in flap, but we have to pay attention not only in the receptor side, but also in the donor side. In the donor side of this patient, in the left tuberosity, because the problem was in the left side, and the upper left central incisor, that's what I recommend, to go to the left side of the tuberosity in order to take the bone. This is my first preference. So you see in these two images, in this X-ray, you can see the amount of bone that we have available right behind the second molar. But pay attention to the CBCT scan, that we can confirm that we have more than we need to perform the IDR technique with this amount of bone available at the tuberosity site. So we have to pay attention and to look for always the tuberosity area. You have to pay attention on that. So I'm going to share with you, Arturo, how we finish this case, apply the IDR technique 3 months after the IDR. Have a look at this. We have the maintenance of the anatomical contour of soft tissue, as you can see here, the maintenance of the outline of gingival margin, and the maintenance of the papillary height position. This is not magic. This is all based on biological properties, all based on biological science. So we have to pay attention to that, because if you intend to live in the most important area of your implant, bone, what I recommend to you, to use autogenous bone tissue in order to replace and to restore the wall that the patient had lost. Because remember, if the bone is going to be there, it's going to be there. After 1, 2, 3, 4, 10 years, the soft tissue is going to be there. And only when we use autogenous bone graft from the maxillary tuberosity, the bone is going to be in the same position. Talk about the height and the thickness of the bone grafted. And if the bone is going to be there, the soft tissue is going to be in the same position. That's the main goal of using IDR in your daily practice.
It just looks, I mean, the soft tissue looks incredible. I'm eager to see the X-ray.
And we didn't add any connective tissue graft in this case. And have a look, the improvement in the soft tissue thickness, if we make a comparison before and after. So in our session today, this is the outcomes that I would like to share with you. The improvement in soft tissue quality, improvement in the position of the outline of gingival margin without adding any connective tissue graft, without open any flap. It makes difference in your daily practice. In my daily practice, in more than 2,000 people that I've already trained over worldwide, it makes a lot of difference.
Definitely.
So to finish our session today, our discussion today, I would like to give you an idea. What are the keys to success in post-extraction aesthetic areas? We have 10 keys that we have to pay attention. The first one is to perform an accurate diagnosis through clinical evaluation, X-rays, CBCT scan, 3D image, scanning of the case. Second, to perform a traumatic extraction, minimally invasive dental extraction always. The third one, to pay attention on the 3D implant position. Implant has to be placed in the correct three-dimensional position always. The fourth, the 3 millimeters of gap to be left in the most important area of your implant, at the buccal aspect of your implant. The 3D alveolar reconstruction, mainly using autogenous bone graft harvest from the maxillary tuberosity. Number 6, always combining with immediate provisionalization to fabricate the provisional restoration with ideal emergence profile. Number 7, the thickness of this new soft tissue around the implant. It makes difference, lots of difference in the outcomes. Number 8, the abutment selection mainly using zirconia abutments, the final restoration, the final crown, and the last but not the least important is the thickness of the new buccal bone wall. I will give you a zoom in this image just to have a look. The new buccal wall completely remodeled and is still stable. And I can also call your attention to the thickness of this new buccal wall. It's still maintained, but not only that, the buccal wall that was placed up to the implant platform still remain and remodel up to the implant platform. If you make a comparison how everything started, have a look before and after. But what's our main goal of using the IDR technique? This is the main goal. To look for the tissue stability. Tissue stability means to leave the outline of the gingival margin and the papillary height in its original position. Or in some case, very complex clinical case, we can also improve the position, not only the gingival margin, but also the papillary height position. This is the main goal of using IDR technique in your daily practice.
What I see here is that many pursue soft tissue stability without understanding that to achieve soft tissue stability, we need to have a healthy and thick enough bone structure. And yes, sometimes a soft tissue graft does not have a successful outcome because in this case, the tuberosity graft, the autograft is responsible for creating this healthy soft tissue stability. And now I understand that is why.
Yeah. Remember what I said before, this technique is all based on biological response. Yes. What's the best bone to be used in the management of compromised sockets? I'm sure 100% is the tuberosity bone graft in order to get an outcomes like this, to get a hard and soft tissue stability along the months and along the years.
Thank you very much for sharing this content, Dr. De Rosa, and I will be seeing you for the next following weeks. And Lord willing, we will have you with us here in person in Ohio this coming August 2023. Thank you so much, sir.
Thank you. See you soon.
Good evening, everybody. Bye-bye.
Thank you, guys. It was awesome presentation.
Thank you, Arturo. Bye,
My
Thank you.
pleasure. God bless
Bye-bye.
everybody. Thank you, team. Camarlengo rocks. Bye-bye.
Yes, it does.